number of patients will present with depression or anxiety disturbance before the movement disorder is actually overt. So about 50% of the patients who have depression associated with Parkinson's disease will present with that before the movement disorder is diagnosed. I am Laura Marsh. I am a psychiatrist, a geriatric psychiatrist, and neuropsychiatrist from Houston, Texas. I am the Director of Mental Health at the Michael E. DeBakey VA Medical Center, and I am a professor in the departments of psychiatry and neurology at Baylor College of Medicine.
Welcome to the MDedge psychcast. I'm Nick Andrews. Last time, Dr. Laura Marsh stopped by to shed some light on epilepsy. In this edition, Dr. Marsh returns. This time, her topic is Parkinson's disease. And don't forget to stick around for Dr. RK. Dr. Renee Kohansky is back for part 2 of her talk on HIPAA, and you don't want to miss what she has to say. And now, Dr. Laura Marsh.
I'm going to talk about psychiatric disturbances that occur in individuals who have Parkinson's disease. Parkinson's disease is a really very interesting disorder from the standpoint of psychiatry and neurology because there's extensive overlap in the phenomena that occur both in Parkinson's as well as in terms of the psychiatric complications. There are many aspects of Parkinson's disease which overlap with psychiatric phenomena and psychiatric syndromes. And it's that overlap that often leads to the underappreciation, the under-recognition, and thus the non-treatment or under-treatment of the psychiatric disturbances in individuals with Parkinson's disease. What's important to know is that when a person has a psychiatric complication in Parkinson's disease, there are so many negative consequences, not just enduring the psychiatric problem itself, but also the movement disorder itself is worse, the cognitive problems associated with Parkinson's are worse, the quality of life is worse, and then even psychosocially, the costs of the illness are greater. So recognizing and discerning when there is a psychiatric disturbance in an individual who has Parkinson's will lead to many other positive ways of coping with the disease. Typically, the most common complication of Parkinson's disease, psychiatric-wise, is depression. And where we see a tremendous overlap between Parkinson's and depression is just in the presentation of the patient. In depression, you can have a decreased facial expression, slowness of movement, slowness of thinking, poor concentration. And so seeing those, often patients are thought just to have Parkinson's and not necessarily a comorbid depressive disorder. So it's important then to look for other aspects of depression that are important, such as a sad mood and feeling worthless or feeling guilty, the usual kinds of emotional symptoms that occur in a mood disorder. A number of patients will present with a depression or anxiety disturbance before the movement disorder is actually overt. So about 50% of the patients who have a depression associated with Parkinson's disease will present with that before the movement disorder is diagnosed. So, and it's important as a psychiatrist, when you see someone later in life with a depressive disorder, to consider whether they may actually have the stigmata of Parkinson's disease. So as a geriatric psychiatrist, I see people in two circumstances. One is someone who hasn't ever been diagnosed with Parkinson's disease but is presenting with depression, or I see someone who has Parkinson's and then has depression that hasn't been able to be treated. Anxiety is also very common in Parkinson's disease and also appears to present commonly both as symptoms or as a syndrome or in terms of treatment before someone actually has the motor disorder diagnosed. It can present as episodic phenomenon or situational phenomena such as panic attacks or phobias, or it can be more chronic, such as a generalized anxiety disorder. But also with anxiety disorders, there can be very Parkinson-specific anxiety syndromes that occur. When someone has Parkinson's disease, as a neurodegenerative disorder, what makes it very nice is that it has very effective treatments. The dopaminergic agents are very, very effective for treating the motor aspects of Parkinson's disease. But as time goes on, the duration of time that one can benefit from that medication changes and becomes reduced, so that there could be these on-off fluctuations in one's response to the medicine over the course of the day, so that when one is responding to the dopaminergic medicine, you will be on and moving, and when the medicine wears off over 3 to 4 hours or so, a person will describe themselves as being off, and they're less able to move. Some people experience, for example, panic attacks or anxiety symptoms as their medicine wears off. And then as their medicine kicks back in and they resolve, they no longer have that anxiety episode. Those can be devastating and extremely disabling for patients and their families because of the distress that the person experiences at that time. There can be other emotional experiences that occur in, for example, waking up in the morning when one hasn't had the Parkinson's medicine overnight and feeling off in the morning. There can also be psychotic symptoms that can be associated with taking the Parkinson's medicine, and as well as other behavioral changes. Dopamine agonists as a class have been identified and recognized for being associated with impulse control disorders, problems like with pathological gambling or hypersexuality, excessive shopping, spending inordinate amount of time on the internet and really being unable to pull oneself away from those activities. When it comes to treatment of these psychiatric complications in Parkinson's disease, what's important is that we first have the correct diagnosis and or diagnoses, because many patients will experience more than one psychiatric complication, and then to proceed with the treatment generally in collaboration with the neurologist or movement disorder specialist who is treating that patient, and to have a good dialogue so that everyone is working together. Many of our psychiatric medications can be helpful, but I want to really encourage also the use of psychotherapies, in particular cognitive behavioral therapy, which is being used to treat anxiety and depression very effectively in individuals with Parkinson's disease. It's also important to get rid of any medications that could be affecting cognition, because Parkinson's is associated with a decline in cognitive function even at the very beginning of the disease. And to remember the benefits of social support and learning the skills that one can have through occupational therapy, physical therapy, the importance of exercise. All of those go together to help one function better. There are many support systems for patients with Parkinson's disease, such as the Parkinson's Foundation, American Parkinson's Association, that have information that can help to educate and extend our clinical practice with patients to help them understand their disease better and all of its related complications, so that they can live a better life with this condition.
And that concludes Dr. Marsh's commentary on Parkinson's disease. We thank Dr. Marsh for stopping by. And now it's time for Dr. R.K. Last week, she began her multi-part series on HIPAA. And this week, well, she's at it again. And now, Dr. Renee Kohansky.
Thank you, Nick. In this program, I continue part 2 on the HIPAA privacy rule. Basically, as most of us know, the privacy rule addresses the use and disclosure of individuals' health information. Within the rule, there are specific instances where, and I quote, a covered entity, and by the way, covered entity includes all healthcare providers, is permitted but not required to use and disclose protected information without an individual's authorization. Now note, most covered entities have standards and procedures guiding their privacy rules, which encompasses the, quote, permitted but not required component of the Act. Some examples where covered entities can disclose information without an individual's authorization are as follows. A hospital may use protected health information about an individual with other healthcare providers about the individual's treatment. Well, this one makes sense, especially in a hospital setting. So, for example, if you're admitted for pneumonia and you develop a cellulitis, it certainly makes sense the treatment team is going to speak to infectious disease. That being said, the individual has also probably already signed a release when they entered the hospital, but even if they didn't, the Privacy Act allows for this kind of communication. Next, a healthcare provider may disclose protected information about an individual as part of a claim for payment to health plan. Well, we have a little privacy creep here as we are all discovering the information released has become increasingly detailed. A health plan may use protected information to provide customer service to its enrollees. Not sure what you all think about this, and I'm not sure what you all think about us getting customer service to the enrollees with this information release. A primary care provider may send a copy of an individual's medical record to a specialist. Okay, this one makes complete sense, but let me put this to you. How many times have you been up against trying to treat a patient only to be blocked by a gatekeeper who delays treatment because you don't have the right HIPAA form? It's mind-boggling to be up against this when you actually don't even need a HIPAA release for this kind of circumstance. Well, the argument one could say is, how do you know the physician requesting the information is actually treating the patient? There are those with nefarious intentions. Well, this is easily solved. When in doubt, err on the side of caution. And of course, forgive me, but there's also logic and just using your brain. But have we become such a big industry and so litigious that there's little room for nuance? And has HIPAA helped or worsened this dilemma? Finally, if we become this big, what have we gained and what have we lost? Can we recapture the valuable essence of what was unnecessarily lost? Continuing. A covered entity may disclose protected health information to another covered entities for certain healthcare operations if the disclosure is for quality-related healthcare operations activity. Again, this is what the HIPAA regulation says. Are your views regarding this relevant? What are your views? So, I leave you with questions and thoughts to ponder and even comment. Did the HIPAA privacy rule of 1996 fill a confidentiality void that was desperately in need of repair? Remember, we've long been guided by ethical decision-making, right back to the Hippocratic Oath. Has this HIPAA rule actually improved privacy, or paradoxically, has it made information more accessible? And is it possible, actually, that the HIPAA privacy rule actually serves as an obstruction to care, particularly when not understood properly? I'm Dr. Renee Kohansky for the MDedge psychcast.
Thanks for listening to the MDedge psychcast. The psychcast is published every Wednesday, wherever podcasts are found. If you have a topic you'd like to hear about or know a guest you'd love to listen to, let us know in the comments section below. For Dr. Laura Marsh, Dr. Renee Kohansky, and all of us here at MDedge, I'm Nick Andrews, and this is the MDedge psychcast.